a 48-year-old male came with complaint of right loin pain since 3 months. Pain was on and off, the leaking type, non-radiating, no aggravating factors, subsides with oral analgesics. There was history of headache, increased sweating, palpitation, anxiety. No history of nausea, vomiting, burning micturition, hematuria, pyuria, lithuria, or fever.
So prior to with this history, what's the diagnosis?
So with this,
only one diagnosis.
yes, sir. With this entire history, my diagnosis is Pheochromocytoma that can lead to right flank pain in presence of other symptoms like headache and sweating, palpitation, physical symptoms.
Why should we have loin pain? It's an uncommon feature in Pheochromocytoma, isn't it?
Yes.
So you have to explain the loin pain.
Sir, if the tumor is large enough, sir, it can stretch of the Gerotas capsule, sir, it can lead to loin pain, sir.
What else? What else can cause pain?
Hemorrhage within the
Hemorrhage, what else?
gland, sir.
Large size, hemorrhage, anything else?
Not sure about the other cause, sir.
Sorry?
Sir, I'm not sure about the other cause, sir.
Not sure about other causes. Can it undergo necrosis and can that cause pain?
Yes, sir.
Yes or not sure?
Yes, sir.
Yes. Any other diagnosis which fits in if you have to add pain also?
Sir. Other than adrenal tumors, sir, renal cell carcinoma may also present with similar features, sir.
Is anxiety, palpitation, sweating a feature of renal cell carcinoma?
Not directly, sir.
No, even indirectly, how will it cause? You don't go there because you're veering off track.
Yes.
You'll get stuck.
Okay,
Pain
sir.
can be explained on these two bases, bleeding or large size.
Okay, sir.
Let's proceed.
Yes.
Dr. Prabhu will ask you questions. He'll lead the discussion, okay? I'll butt in when I feel like.
Sir.
There's no history of loss of appetite and loss of weight, or jaundice, back pain, cough, seizure, hemoptysis. He's known case of hypertension and he's on 2 antihypertensive medications. There is no history of diabetes mellitus, tuberculosis, or previous surgeries.
Yeah, I'm happy that you have written the medications for the first time. But this anxiety, the duration of taking these medications is not told. If we have, fine, otherwise we proceed.
Okay.
So usually, if you're suspecting Pheo, what all additional problems or symptoms you would have encountered other than what is mentioned so far? See, the one classical is the symptoms. How many patients with pheochromocytoma may not have the classical symptoms? It may be incidentally picked up also in about 10%. You know, one of the times it used to be 10, but now they're saying it's not a 10%. Anyway, but some of them may be detected during routine workup for hypertension also. If the patient is on one drug, two drugs, three, I mean, its number of antihypertensive drug medications is increasing, then you have to see whether there is any secondary cause of hypertension. Then the workup is done and they do an ultrasound and then they pick there is an adrenal lesion. So that is one other presentation. Increasing requirement of antihypertensive, accelerated hypertension. Sometimes the patient goes to ophthalmologist, he finds there is a papilledema, and then, this is diagnosed. These are various presentations. I mean, the patient can go to different doctors. That's how it is described. He may go to a psychiatrist, he may go to a ophthalmologist, he may go to a gastroenterologist because some upper abdominal pain and all those things. So it is how the patient can land in different departments. Anyway, proceed.
On examination,
See, in any major case, go to the previous slide. Has he written no edema, no all that? History, yeah, finished, no? No.
History finished.
But no weight loss and all that. Oh, right.
1/90, complete was 86. There are no palar clubbing.
Can't hear whoever is speaking.
There was no palar clubbing, icterus, cyanosis, lymphadenopathy, neck swelling, no pedal edema. Cardiovascular and respiratory system was normal.
So you are examining cases of hypertension, especially if you're suspecting a pheochromocytoma. Which part of the examination you will give more importance?
Pressure, pulse, presence of sweating in general examination. Pressure has to be checked in supine position. Any evidence of orthostatic hypotension, all those things has to be.
Yeah, other than the hypertension, you may not get other findings. So you'll have to check the blood pressure. Even in the exam, I mean, you don't say that the BP are not checked. Now, commonly in exam, you just do examination, but you don't do vitals. So the BP has to be recorded in cases where you are suspecting some adrenal lesions.
Okay, sir.
Supposing he had pallor. This patient didn't have, but let us say there is a patient who has pallor with the same symptoms and the same examination findings. He had pallor also.
So hemorrhage within
The hemorrhage to produce pallor must be quite massive.
hemorrhage.
Correct. His history is not of an acute history with hypertension, fainting, and so on.
Malignant pheochromocytoma.
Why should it cause pallor? Can a solitary intra-abdominal retroperitoneal pheochromocytoma produce pallor? Pheochromocytoma causes vasoconstriction, universal vasoconstriction. The vasoconstriction can give an impression of pallor.
Okay, sir.
It's important also to look at skin temperature. Whoever has written down the history, because these patients usually have cold extremities. Because of the vasoconstriction, again, they can have cold extremities. On the other hand, you might find because of the hyperdynamic circulation, the patient has a feeling of warmth, might be feeling febrile, and the extremities might be warm. Both these are possible.
So Priyanku, not related to this case, suppose the acute presentation, which adrenal lesion causes acute presentation with pallor and shock? What is that syndrome called? Acute retroperitoneal bleeding. Yeah.
Wunderlich syndrome.
One.
Wunderlich syndrome.
Wunderlich.
External genitalia were normal. Digital rectal examination showed normal tone. Grade 1 prostate, which was form inconsistency. Spine examination was normal.
Something is left out. Someone has examined the spine, but is something else left out. Oh, you've written, okay, fine, carry on. Difficult to believe that CVS was NED. You got a pulse rate of 86, which itself is an abnormality. So be a little careful when you write history like this.
Yes.
Yeah.
I think he's on propranolol, correct? So maybe.
Yeah, propranolol still on an 86 pulse rate. Tachycardia must be part of the cardiovascular examination, isn't it?
Yes. Pulse was normal 86.
Why do you think he was on propranolol?
Old drug, no? There must be a reason. It's an old drug. There must be a reason.
He has history of palpitation, sir. That is why he must have been given propranolol by some physician.
How does it help?
Yeah. Beta blocker by its excellent beta 1.
An anxious person gets palpitations.
Sir, I had a cardiac evaluation and there is a condition of benign something tachycardia, and they do give propranolol for some of these patients. He may be an anxious fellow, and that's also another reason why they gave propranolol. Of course, in the old days they used to give it for thyrotoxicosis also, so there must be some reason.
Proceed.
By one?
What do you want?
Yeah. So, what do you want to do now before you have examined this patient? So, what are your thoughts and what test you want to plan?
There are routine blood investigations and specific investigations in this line of the suspected diagnosis, sir.
Okay, suppose I say this is an incidentalloma. Do you agree with the diagnosis or you do not agree?
Yes, sir. can be an incidentaloma because 20 to 25% of incidentalomas are Pheochromocytoma.
No, can this be
20
a
to 25% of Pheochromocytomas present as incidentalomas, sir.
no, the question is, can this case be an incidentaloma?
When do you call something an incidentaloma?
Sir, any detection of any mass in the adrenal more than 1 centimeter on imaging, sir.
Is there any other criteria? Is there any clinical criteria? See, the term itself has the criteria in it. Accidentally discovered mass in a patient who is asymptomatic.
Asymptomatic.
You are looking for something else and then you find this in the adrenal. So, Dr. Prabhu's question is, can we call this an incidentaloma?
No, sir. This patient has got specific history, sir. Specific.
Yeah. So, if you are looking for an adrenal lesion and you find a tumor, then it is not an incidentaloma. If you are doing a test as a routine, patient has come for some health checkup, and then you find it. The patient has no hypertension, no palpitation, nothing. Then you find an adrenal lesion, then it's an incidentaloma. It's not 1 centimeter. It's, I think, 4 centimeter and above are called incidentaloma.
Some people say 3, but some people say 4. So it's it's certainly not 1.
Okay.
You said more than 1, so that's the only problem. More than 1 can be 10 also. There is a range, anything 3 to 4 centimeters usual. Why is it that it is only 3 to 4 centimeters? Why is there a size criteria fixed for this incidentaloma?
Sir, size larger than this will have specific localized symptoms, sir.
No, not necessarily at all. Not necessarily at all. Remember, these patients are asymptomatic, isn't it?
Yes, sir.
So this size criteria becomes important for one particular reason. And that is, the higher the size, the greater the size, the higher the chance of malignancy. Right? That is the reason. And therefore, it becomes necessary that when you have something that is 6 centimeters, incidentally detected, this can be an adenocortical carcinoma.
Okay, sir.
That is the reason.
His hemoglobin was 11.2, total count normal. Platelet count 340,000, creatinine 1.12. Urine analysis showed RBC nil, WBC 1.2, albumin nil.
Yeah, all good. That's like unique to them. Priyanka, you want to describe it?
Yes, sir. So,
Don't take such a long pause, man.
Yeah, the ultrasound image showing the right kidney and the left kidney in the first image. Both the kidneys appear to be normal in ecotexture, contour. There is no evidence of any hydronephrosis or any echogenic lesion or calculus.
Priyanko, many times you've all been told how to describe the kidney on ultrasound. Do you start with echogenicity? I think even the last discussion we discussed this. Shape, location, size. Begin with that.
Okay, sir. Sorry, need to describe both the kidneys different separately, sir.
Preferably, yes.
Yes, sir.
If they are normal, your description can be short, but it's preferable to refer to both differently so that we know that you have looked at both images.
Yes. The right kidney appears to be normal in size, contour. Normal corticomedullary differentiation can be seen. Sinus echo complex is normal. There is no evidence of any fullness of the collecting system. There is no evidence of any echo-reflective calculus.
Say calculus. Why echo-reflective? Do you have non-echo-reflective calculi?
No, sir. No.
Now you said the sinus echo complex is normal. Take a look again. Doesn't it appear split to you? Two distinct moieties with a central separation?
Centrally, yes, little bit.
You might not be
On the right
abnormal,
kidney.
it will be a normal variation, but you'll get brownie points if you mention that. Okay.
Okay, sir. Similarly, the left kidney also appears to be normal in size, contour, normal with normal corticomedullary differentiation without any evidence of calculus. And in the next image, we can see the upper pole of the right kidney, which shows a definite definite lesion of mixed echogenicity, which is globular in contour, having it is well defined solid lesion. We having both hypoechoic and hyperechoic.
What is a predominant echo texture?
Hypoechoic, sir.
Hypoechoic. So predominantly hypoechoic lesion, well circumscribed, with areas of altered echogenicity in the center.
In the center.
Morning.
So what do you want to do? Once you see an ultrasound report like this,
Yes, sir. Ultrasound points out to an adrenal mass, sir. We'd like to do specific investigations in the line of Pheochromocytoma based on the patient history, sir.
Instead of saying that, can you just say, I would like to do this, as my diagnosis is Pheochromocytoma?
Yes, sir. Sir, plasma-free metanephrines or 24-hour urinary metanephrines, sir. Which is the most sensitive test in Pheochromocytomas.
I would put the question differently. Now, if this patient again was an incidentaloma and you find this lesion like this, what you would have done it? Now, in this case, you are right. I'm taking you to another scenario where it was incidentally picked up and what test you would have done in that scenario.
Sir, contrast CT, sir.
No, we are continuing the evaluation, what you said, metanephrines and all that. Any more tests you would have done if you had incidentally picked it up with regards to the biochemical or test, what you were mentioning?
You found a mass, incidentally, in the adrenal region on the right side, correct? What are the differential diagnoses of an adrenal mass? Pheochromocytoma, you've already said. What other mass lesions can present?
See, there's a famous classification for all adrenal lesions, basically for all lesions which are functioning. Follow that.
Yes, sir.
Is it a functioning mass or a non-functioning mass? Is it a benign mass or is it a malignant mass? Finish. That's all.
Yes. Whether it is a Pheochromocytoma, adrenal hyperplasia, sir.
See, I think you have read the topic on Pheochromocytoma and come.
Yes.
That's the problem. You should, I may change the whole thing at this thing in exam. Because I know that you are going in this line, I will divert the question. So that's how we come to know whether the candidate has studied or not. So what are the functional tests in a case of adrenal lesion? Is a simple question.
Serum cortisol levels, urine cortisol levels, then electrolytes.
See, again, it is very simple. Instead of thinking about it, you know the adrenal has got two parts, isn't it?
Yes.
Let us say what's arising from the cortex and what's arising from the medulla. Whether it's functioning, whether it's non-functioning. Khalas, what is that? Not so difficult. Whether you prepared Pheo or not prepared Pheo, this should be there, ingrained. Dr. Prabhu is absolutely right, you know. You can make out whether somebody has known the diagnosis. That is the biggest pitfall, you know, in the exam.
You said cortisol. When do you do a cortisol level? The patient has met you at 12 o'clock in the afternoon. Can you give the sample now?
Morning samples should be taken, sir. 24 hours urinary free cortisol has to be checked, sir.
Which is more commonly done? The way you are answering, I can tell you never asked for such test.
Sir, 24 hours urinary free cortisol is done, sir.
24 hours urinary free cortisol.
Priyanku, when you have a choice of a test which can be done at short notice and where you can get the results early, why would you wait for 24 hours for a urine collection which may or may not be accurate? You want a diagnosis quickly. So what tests will give you those diagnoses? Is the result of a 24-hour urine test available early, or is the result of a blood test available early?
Blood tests, sir.
Then why do you want to do 24-hour urinary cortisol?
Yes, sir.
What blood do you do?
You can do dexamethasone suppression stress test.
I think, this is something you didn't anticipate. Please go.
Can do, sir.
Read about this. Praveen. Please read about this. We are going to ask you in the course of the next few cases. I'm sure something will arise. We are going to ask you. It's very common, particularly if there is a paucity of cases. The same case can come to you after it's been seen by another candidate, and in which case the treatment or the management will go completely away from Pheo into an adrenal tumor.
Yes.
You get it? And even when you have a patient on hand, you might think it's a Pheo for various reasons, it might turn out to be something else. You must know how to go about it systematically.
When you want,
sorry.
Yeah, so Priyanko, so if you are asking for plasma metanephrine, any precautions you would like to take?
Yes, sir.
Or simply tell him go and give a plasma metanephrine?
Sir, we have to collect it in the supine position, sir. And patients should be ideally asked to take 30 to 1 hour of rest before collecting the sample, sir.
What else?
Sir, we should ensure that the patient does not have any intake of certain drugs like acetaminophen. We have to rule out history of any psychiatric medications or antidepressants. So, and after that only we can collect.
This patient is on those drugs. So what is the advice for him?
And for everybody, my suggestion is don't call them psychiatric drugs. In this context, there are specific drugs we need. In any context, we need to know what drugs, not just some psychiatric drugs.
Yes, sir.
It's also important to remember that one of the manifestations of Pheochromocytoma is actually some sort of so-called psychiatric illnesses. Patients can present that way. Very varied.
Have you done the metanephrine?
Question.
You have to keep pushing forward.
Yes, sir.
You won't get enough time in the exam to go like this. If you slow down, they'll think you don't know.
Yes. Sir, I would like to ask for metanephrine, sir, plasma free and even metanephrine, sir.
Okay, let's see what they've got.
Slide is not moving, sir. Yes, it's moving.
Do you agree with the last recommendation of the radiologist? He says suggested CT for further evaluation.
Yes, sir.
Would there be anything better?
Priyanku, you must be able to take the hint. You see, he did that in the CT appropriate investigation. You know, you're making a diagnosis here of Pheochromocytoma. Immediately there should be a bell ringing somewhere that indicates, aha, there must be a better test for that. And, you know, everybody talks about the so-called light bulb appearance. So that is seen only in the MR.
MR.
So that's the, you know, you should take the clue. In the exam also, it is important to actually take a hint which the examiner is giving. It may be examiner 1 or examiner 2, you don't know who will give it, but you know, sometimes hints are given.
Yes, sir. Sir, I'd like to do a contrast CT, sir, because there is characteristic contrast uptake in Pheochromocytomas, sir, which will better delineate the tumor.
Wait, Priyanku, wait. Between MR findings in Pheochromocytoma and contrast CT findings in Pheochromocytoma, which has the higher accuracy. See, once you're given a hint by the examiner, grab it with both hands. You've already been asked, would you do an MR or would you do a CT? You said you would do an MR. Why are you going back to CT again?
In which situation would a CT scan have been appropriate in this patient? Forget the his symptoms and all the rest of it. But there's a sign that there's a lesion in the adrenal, incidentally detected lesion in the adrenal. And in which situation would a CT scan be more appropriate? Are there other conditions in the adrenal gland where a CT and certain maneuvers done in the CT scan make diagnosis for us?
Adrenocortical carcinomas are in case of suspected malignancy, malignant pheochromocytomas or CT.
Adrenocortical carcinoma is fine, but the CT scan, even the MRI would be useful. But the CT does has a specific value in certain adrenal conditions. Which the radiologists use. Benign conditions. We are not very certain whether this is benign or actually malignant.
Yes, sir.
Yes. Because just because it's small in size, it doesn't mean it cannot be malignant. It can still be malignant.
Yes.
So a CT. Have you heard of washout?
Yes.
And then what's wrong? If you heard of it, hey, talk about it. What is your hesitation, man?
Yes, sir.
Okay. The problem with adrenal is that it's a rare condition for all of us. It's grabbed mostly by the endocrine guys. And we tend to keep forgetting it in our day-to-day dealing with stones and prostate cancer and all the rest of it. So we get stuck when somebody asks a question like this in the exam. And as Mohan said, for sure you will have somebody with an adrenal lesion. I mean, if it's there, it's going to be kept. So we cannot afford to give away adrenal gland. So it's still.
So it is early enhancement with early delayed washout.
No, I'm just giving you the question. You proceed with this case, otherwise we'll be wasting time. Carry on.
So 24-hour urine metanephrine is beyond normal limits are 850.
It is 850.
Yes. Under plasma aldosterone ratio, it is normal. Sometimes, if we suspect aldosterone secreting adenomas, we can it would have been raised beyond the normal limit. So the only positive finding from this testing is 24-hour metanephrine, which goes in favor of Pheochromocytomas.
Go on, you should ask for the next thing, Priyanku. Please keep going on.
So these are the plain axial images showing the mass lesion in the right adrenal gland. You can see in the third image. Both the kidneys otherwise appears to be normal. Can I see all the images? Okay. Next.
Priyanku, this shows you anything you wanted to see. So can we please have your description and move on?
Yes, sir. Sir,
Go on, Priyanku. No, go back to the axial slide, please. Yeah.
sir, you can see that both the kidneys are showing normal.
Are you interested in the kidneys?
No, sir.
So begin with the lesion of interest.
In the third image, we can see that there is a you can see the adrenal gland, which is showing diffuse uptake.
Is it normal size, abnormal size?
It is increased in size, sir.
So you have to begin with that, isn't it? There is an enlarged adrenal gland, and then it is irregular in shape. Correct?
Yes, sir.
Then go on.
Irregular in shape, well-defined borders, showing diffuse contrast uptake.
Is it called diffuse or is it called something else?
Heterogeneous contrast uptake, sir.
Very good. Anything else?
Without any evidence of calcification within the mass
or calcification or
hemorrhage.
Necrosis. Hemorrhage. Okay. And then anything related to a large adrenal mass that you want to see on a CT, leave the kidneys out. Anything else you want to look at in a CT?
Sir, attenuation, sir, how in terms of Hounsfield.
All that's okay. Other than the adrenal, anything else you want to look at?
Evidence, any lymph nodes, sir? Evidence of.
So comment on all those. Why do you wait for us to ask?
Yes, sir.
There is this lesion, variegated in appearance, but appears well contained. The adrenal is enlarged to begin with. The uptake, again, contrast uptake is variegated. There are no calcifications, there is no necrosis. The kidneys appear normal. There is no lymphadenopathy. Or there is lymphadenopathy. Whichever way you look at it, whatever you find, that's how you should put it.
It's also worth commenting on the perivascular organization. Any other, like you see in renal carcinoma, you see a lot of extra vessels, you see a lot of vascularity around. So sometimes these adrenal lesions can be extremely vascular.
You also have to look at any adrenal vein and renal vein thrombosis. Adrenal lesions are known, though Pheo may not be, but you should look for the vein if you are able to identify.
Well-known adrenal cortical carcinomas can produce both renal vein as well as IVC thrombus.
Yes.
During surgery, you are worried of what? The artery, the vein, or lymph nodes? What are you worried about on the right side?
Vein, sir. Vein, sir.
Yeah.
Because it is proximal to the
Not
IVC.
just because it's proximal, also because that's what is carrying all this stuff into the body. Correct?
Usually, the adrenal vein, there are two problems with the adrenal vein in these sort of lesions. One is the size. The normal adrenal vein is not very large. But here, because it's a pheo, the adrenal vein is very large, number one. Number two, there can be more than one adrenal vein.
Okay.
Number three, it's the location, the anatomical location of the adrenal vein. Its entry into the vena cava is not lateral, it is posterior and medial. So, it's difficult sometimes. And it's a short, stubby vein.
Awesome.
So that's the problem with the adrenal vein on the right side. And that's why the specific question asked by Prabhu. And there are many, that's the only answer is not that. There are many reasons why that question was asked. What is the problem with the adrenal vein on the right side?
So you have seen the CT now. So will you take him for surgery tomorrow?
No, sir.
Why not?
What happened?
His blood pressure might go high, he might have a stroke, he might have a seizure, he's worried about all that. I'm ready, operate.
Patient says, next festival is coming. I want it early, quickly.
No, sir. We cannot go for surgery straight away, sir, in case
What?
of from.
All workup is
this
done.
in the exam, Hardik, begin with, because these risks are there, early surgery is not possible. Don't begin with no, sir, early surgery is not possible. And
Yes.
then wait for the examiner to ask why. You come out with the risks upfront.
Because of the risk of uncontrolled hypertension intraoperatively, and that can lead to complications, we have to.
What is the main problem
optimal-
with adrenals? Is it hypertension or is it something else?
Rebound hypertension, sir.
No. Preparation in Pheochromocytoma surgery is required for hypertension, definitely, but there is something else which is more important.
Something more cardiac.
Fatality on the
Something more
table.
cardiac, which these drugs help to do. The word begins with A. The answer begins with the word A.
Ends with A also, sir.
Correct. Arrhythmia, man.
Yes.
You've got drugs to control hypertension surges, they can put an SNP drip and all the rest of it, But this arrhythmia is a very tricky issue.
Yes, sir.
You can go into ventricular fibrillation. And can you imagine doing an operation like this in the lateral position and then the anesthetist says, you got a V-fib, man. What are you going to do? Huh? So it's because of the complications as a result of surges of these metabolites that causes the problem.
What hormones does the Pheochromocytoma secrete that you're worried about?
So epinephrine and norepinephrine, sir.
Which is a major hormone in a pheo of the two?
Epinephrine, sir. 90% of the pheochromocytoma are adrenaline or epinephrine secreting, sir. 10% are norepinephrine, sir.
Both of them have a vasoconstrictive effect?
No, sir. Epinephrine has got vasoconstrictor effect, sir. Norepinephrine does not act on alpha 1 receptor, sir. Epinephrine acts on all the receptors, alpha 1, alpha 2, beta 1, beta 2, and norepinephrine acts on the rest, sir, other than alpha 1.
Okay, now when there is sympathetic overactivity due to adrenaline, what happens in the body? We've heard of arrhythmia, we've heard of brain, we've heard of, in respect to the entire body and
Yes.
the fluid balance in the body, what happens? Which is why the anesthetist will put in 2 or 3 lines, not just for measuring arterial pressure and a running blood, but for other things also.
Central venous pressure.
What happens to it?
Sir, because of unopposed beta blockade, sir, there can be significant drop in pressure sometimes, because if it is a norepinephrine secreting tumor and we have used alpha blocker before the surgery, then it can cause unopposed action of beta on beta 2 receptors, so that can lead to vasomotor reversal of Dale phenomenon, sir. That is also and
What happens is there is a volume contraction.
yes, sir.
Due to vasoconstriction, there is volume contraction. And when you remove the vasoconstrictive chemicals after ligating the vein, there is a sudden vasodilatation, drop in blood pressure. Right? So one of the things that you have to do before you decide on surgery is to expand the extracellular volume so that this drop doesn't take place. That's part of the management. Yes, hypertension, antihypertensives, yes, sedatives, yes, and making sure that there is enough volume expansion either on the table or preferably before the surgery. And that's why they have that big central vein running so that they can run fluids, and sometimes it might be required to run colloids rapidly.
Yes.
So how will you control his pressures and what is the timelines before you plan the surgery?
Sir, usually 10 to 14 days before surgery, we need to start on alpha blockers, sir, preferably with phenoxybenzamine. Then after that, we have to start the patient on IV fluids after around 3 to 4 days of starting alpha blockers. We have to admit the patient and routinely check his vitals.
After 4 days till after 4th day till 15th day is on IV fluid.
Sir, usually plan it within 7 to 14 days, sir. So in patients where we can see contracted blood volume or evidence of hypotension, those patients we have to start them on fluids, sir, as well as supplementary salt. And patient has to be admitted in the hospital for routine observation of his vitals, sir, blood pressure, predominantly the blood pressure recordings.
So you have asked for phenoxybenzamine, the patient goes all around the city, he doesn't get it. So what do?
That's a very important question because the drug is not freely available. There's a problem with its production.
We can start the patient on calcium channel blockers in that case, sir.
Are there any other drugs apart from, phenoxybenzamine is what, alpha blocker or beta blocker?
Alpha blocker, sir.
No, phenoxybenzamine has got dual action actually. More of alpha, but it does have a dual action. It's not, so any other drug you can use apart from calcium channel blockers? Quite a lot of endocrinologists use it actually also, simply because of the non-availability of this phenoxybenzamine.
Urologists used to use it too.
Yeah, urologists also used to use it like anything before tamsulosin and all that came in. Prazosin, all right? Yeah, prazosin is also useful in these situations. Yeah, you're right about calcium channel blockers.
Prazosin, sir.
Some people use solely diltiazem, some people use nifedipine, but basically you want to control everything. You want to control these episodic bursts of tachycardia, you want to control the arrhythmia, and you want to control the fluid, the dilatation which happens as a result of. When you want to control the tachycardia, you give the beta blocker that causes a vasodilatation, and you want that is recognized by the fact that the hemoglobin drops or the hematocrit drops, and then you got to pump it up. So these are all things that are standard. And every resident is expected to know this because in the exam, somebody will get a few, and you just got to rattle it off.
So you are going to increase the alpha blocker to what point?
Sir, 10 to 20 milligram.
No. Clinically, how will you decide alpha blockade is adequate?
There is adequate alpha blockade and this much is enough. How do you decide that?
Yeah. Sir, we see on the blood pressure, sir. If the blood pressure is managed up to around 120 to 130 systolic pressure, then we think that the alpha blockade is sufficient, sir.
Is there anything else you will do to establish that alpha blockade is sufficient, or sometimes wonder whether it is excessive?
Unless you have read it, it's difficult to answer these questions. These are specific questions. The patient, you have to see whether there's any postural drop.
That's one of the risks of alpha blockade.
Yes, sir.
They develop both orthostatic hypertension and postural hypertension.
Yes, sir.
So the point is to alpha blockade to a point where they don't have dangerous postural hypertension.
Hypertension.
Right? So it's not dependent on the measurements of the blood pressure alone. It is also dependent on checking postural fall and asking the patient for symptoms. You might not be able to elicit the symptoms when you're recording the BP, but the patient will tell you, when I get up, sometimes I feel giddy. Or in the bathroom, I felt giddy. Okay.
Two days prior to surgery, what do you want to start?
Sir?
You are given alpha blockers. Now, 2 days prior to surgery, what else you want to do?
Sir, beta blockade, sir. Beta blocker.
Selective, non-selective.
Selective beta blocker, sir. Like etinolol or metoprolol, sir.
Okay, what approach you will plan for surgery?
Laparoscopic adrenalectomy, sir.
What are the critical steps during the procedure?
Certain principles are common, whether it is laparoscopic surgery or open surgery. So what are the standard precautions to take when you're operating on the adrenal? Let us assume you're doing it laparoscopically. You're very good at it, but what are the precautions you will take?
We have to ensure invasive continuous blood pressure monitoring along with
No,
central
all that
venous.
okay, surgical. That the anesthetist take care of, isn't it? We rarely bother about that
Yes, sir.
until the anesthetist say you stop. Which rarely happens today. They manage it quite well.
These tumors are quite vascular, you know. These tumors are quite vascular. And therefore, the question revolves around how to reduce the vascularity. I just told you, some time back, what are the problems with the right side. Well, for that matter, even the left side, the principle is the same. What, Priyanku, you're not very sure. I think everybody needs to go back and read adrenal lesions, and come again, maybe.
Sir,
Adrenal surgery also. See, there are two things here, Priyanku, two major issues. One is of diagnosis and the second is of operative management. Right? You have to be well read on both. At this level, we can't really have much of a discussion.
Do you know any intravascular beta blocker?
Something given for acute hypertension or acute arrhythmias. Have you heard of labetalol?
yes, sir. Good.
So I think Dr. Ganesh has made the point already. I think you should all go back and read all about this, including the drugs which are used, which drug has to be used, what are the limitations to drug use, preoperative monitoring, surgical procedure, precautions while performing surgery, and post-operative management. That's also even more important. When you'll operate and go away, but post-operative management is critical. These are things you'll have to read up. I think we're past 9.
Yes.
Can we stop here?
Okay, sir.
Thank you.
Thank you, sir.